immediately you log in, you get your details. So please don't send in your details. The Q&A, if you've noticed, we've been removing them once you post them. Keep your details private. We're able to access them. Sorry, I can only see your device name, Galaxy A10. I don't know. I don't know whether your name, so it's a bit difficult not to follow up. Oh, the other concern from the PPB is that once you register with the PPB portal, they're able to see your name. But when you come in and they're trying to confirm with the database of the attendees, the only thing they can see is the device name. So there's a suggestion and the feedback that we got is that could you kindly be registering with your name? If possible, register with your name, not your device name. Like now, the person who's Galaxy A10, kindly rename your device or rename yourself so that the people who are entering your points can be able to confirm that you attended this session. So the process is once you from what I understood from the PPP point, once you pick up the session and you log in, they still have to come and confirm that you actually attended the session. So with a device name, it is challenging for them to know who you are and whether you attended or you didn't attend. John Mwangi, I don't know whether it would be good to tell us whether you're a pharmacist, farm tech, dentist, nurse, or medical doctor, so that you can follow up about your CPD. Albert will follow up, as I've said. Newton Liai, if you logged in for this week, as I've said, once Friday, at the end of Friday, once they finish all their work for the week, the team sits down throughout the whole weekend. Sometimes you'll even see an email on Saturday past 11 p.m. at 1 a.m. They're still sending you emails. They're trying their best to deliver your points to you. And we truly appreciate that team for all the work they do. So be patient with them. And we acknowledge their efforts and appreciate that they volunteered to do this. It would have been unfair for us not to have you getting any points despite attending these sessions. Thank you, Dana Menya, for that feedback. Yes, the CPDs are coming in. Slowly but surely, yes, they will all come. All of them will come. That rest assured that your points will come. Kevin Ocheng, for pharmacists, that one you'll have to follow with cpdknhpharmacy@gmail.com. But also, again, as I requested, kindly be patient with them. They still have to do their day-to-day activities and their day-to-day work. And during the weekends, at their free time, is when now, actually they don't have any free time, as I've said. That's the time that they sit in and ensure that you get your points for the week. So let's be patient with them. Let's bear with them. And let's also be kind in the emails that we send that particular team. Let's just be a bit kind to them. They're trying their best. Unfortunately, the PPB process seems to be complicated, unlike the medical council one. And the nursing council and the clinical officer council, the PPB system is a bit too complicated for us to handle it. So it's the team from pharmacy that is handling that particular point. Jacqueline Ocheng, it would be good to let us know your CADA so that we can be able to follow up. If it's pharmacists and pharmaceutics, I think I've already said that you bear with the team that's doing that. For nurses, yes. If you're within Nairobi, feel free to come to KNH Research and Programs Department. We will sign your booklet for you. For the other people who are outside of Nairobi but have been attending the sessions, the nurses outside Nairobi who've been attending the sessions, we're trying to see whether the email Nursing Council of Kenya will accept that email in lieu of a signature, or the token point in lieu of a signature. So that's part of the conversation, but rest assured your points have not disappeared. If you need an email from us, just let us know at knhresearch@gmail.com. Then we'll be able to send you an email to show that you attended. There is evidence that you attended the session. But if the question, if it comes in as an anonymous attendee, we really wouldn't know who you are. But you can just write to knhresearch@gmail, and they'll be able to confirm that you attended the session. Nehemiah, the PPB process, as I've said, is a bit complicated. We tried to handle it, but we were not able to. There's a KNH research, so the pharmacy team is assisting us in that. And just ask them, cpdknhpharmacy@gmail.com. They'll be able to address your concern, especially if you put in your name. If you logged in with your name, Nehemiah, you can follow up with them. And as I've said, remember to be kind in your emails. We've received quite rude emails. Yeah, we've received quite a number of very vocal, if for lack of a better word, emails, but we understand. Beatrice Kioro, yes, for the nurses, I've said, if you're within Nairobi, you can physically come for your signature. If you're outside of Nairobi or even within Nairobi but can't come to KNH, just let us know. If you need an email, we will document, but we are aware that you attended all the sessions. All the sessions you've attended, we have the evidence that you attended, and it's very easy to just say that these are the sessions you attend, and we send you that copy. Thank you, Steve. At least I can see somebody's acknowledging that their points have been uploaded. Asante sana, Steve. I'm sure Dr. Rosalind Kinuthi and they work on this forum, and they're feeling appreciated now. So thank you for that. We appreciate. All right, enough about CPD points. I think we should start our session now. Yes, we're starting our session, and today we're going to have a very interesting topic. We are going to hear from the sorry, I'll write that email address again. We're going to hear from physiotherapists. And we are very happy that we're having this conversation, because it's a conversation that is very timely. It's a conversation that was requested a while back. There's a time we had a session on the respiratory effects of COVID-19 and to intubate or not to intubate severe disease. So the question about chest physiotherapy came up. And today we are very excited that we have a team that is actually doing that on the ground, the technical experts coming to talk to us about this. We have representatives from Kenyatta National Hospital who are on the front line. We also have KU, Teaching and Referral Hospital. We have Aga Khan University Hospital. And if we do get Mombasa, we'll be able to put them up so that they can be able to tell us what they're doing. So thank you for logging in for today's session. I'd like to hand over to Kennedy Mugire to take us through this session.
Thank you very much, Dr. for that introduction part of it. And welcome all the participants to this forum. Today, we are going to talk about the role of physiotherapy in the management of COVID-19 patients. Dr. Kalonda has just summed it up. Chest physiotherapy is a very part and parcel of management of COVID-19 patients, and physiotherapists play a role, quite a big role, in the front line. Indeed, and as you are aware that most of these patients present with a lot of complications associated with that. So our physiotherapist's role is basically to prevent, minimize, and as much as possible, patients who are coming out of or recovering from this COVID-19, they could be able to lead a normal life and back to their normal day-to-day lives. So we are going to go through briefly. It's just an overview. I'll first look at the overview of our setup. Most of our patients are actually asymptomatic. We have quite a majority who have been asymptomatic, and they range from young to the middle-aged. Others, as you realize, even from the recent, we have those who have tested positive as much as even going to the 8 years. Stable, sometimes they are stable and mobile. Most of them, they present not that badly sick as such. So far, the latest, we have not had many cases of who have gone intubation to be intubated, but as we are talking, could be having those suspected who could be intubated right now. Now, our setup is restricted to very minimal movement with the isolation areas, and the majority, because of this isolation and because of the nature of isolation or the place, so majority of our patients, they tend to end up with the musculoskeletal ailments, which can be related to poor economic environment in terms of not enough to stretch or to have movement a lot in wherever they are. So, so basically that's our setup. Now objectives, we look at the COVID-19, the coronavirus 2019. There's a lot of etiological manifestation, and we look at the strategies for the physical examination, management, and evaluation for patients with COVID-19. It's very important that I should emphasize this fact that the assessment examination is tailored to individual patients, and it's through that one can be able to deduce what is a management plan and be able to carry out effectively. We should also outline the physiotherapy intervention in acute, subacute, and post-acute stages, and as well articulate the importance of physiotherapy in post-discharge and optimal functions in activities of daily living and instrumental activities of daily living. Now, severe acute respiratory syndrome or coronavirus 2 or COVID-2 is a new coronavirus, and this disease emerged in the year 2019, and it causes coronavirus disease, and it was named COVID-19 by the World Health Organization. Now, this is a new disease in the world. It's a pandemic now right in the world, and including physiotherapists, to come out clearly and be able to devise ways and mitigation factors in minimizing complications and the effects of this disease. Most of these patients, as we have seen, and elsewhere, where we are in the part of the world, the signs and symptoms which are presenting, fever is what is coming out clear at over about 89%. Patients present with dry cough, and this percentage can range up to around 68, between 68 and over. Patients presenting with fatigue, we have about 38% from the literature we are seeing. And sputum production, of course, we have that percentage, then shortness of breath as well. As we say, as we have witnessed, this patient, a lot of this complication can differ from one patient to the other, but mostly this is what we encounter in the most of clinical situations. Current reports also say that about 80% of cases are asymptomatic or mild, and as I've said from the word, like in our setup here, 15% of cases have severe infection requiring oxygenation or oxygen therapy, while 5% could be in a critical situation requiring ventilation and life support. And this is what we are seeing, as we have seen the world over, especially in where we have been dealing with the worst cases, like in those countries like Italy and the USA and such, etc. But there is no doubt that there is increasing evidence that reducing bed rests, inactivity as much as possible by early mobilization and activation in the ICU are giving promising interventions in the prevention and reduction of the consequences of bed rest, and of course in critical condition and in acute stage. This is early mobilization, as physiotherapists can attest, that in setups of this, not necessarily even in COVID-19, but patients who have been put in a place like ICU, critical care unit, early mobilization, and of course, early interventions go along, preventing a lot of complications and the consequences of immobility and etc. As we look ahead, the COVID-19 disease as such, there are lots of risks, of course, associated with this disease. And a lot of mitigation factors are in place to prevent the spread and also minimize the spread, as well as when we are managing these patients as physiotherapists. And the actions, also the use of PPEs, personal protective equipment or personal protective gear is very crucial. And as you can see that we have got guidelines not only from our government, but this are also guidelines given by the World Health Organization. And we are following them even in terms of the larger population. But in our case, we need to emphasize that the hand washing by use of water and soap for at least 20 seconds is very important. Then sanitation, using alcohol-based sanitation is very important. And of course, issues like social distancing, which is a way along in preventing the spread and cross-infection of this COVID-19. And the wearing of masks in our clinical setup as physiotherapists, this is a part and parcel, because if we are in the front line, and we need to be careful on this, and also the use of goggles where need be, or shields, or use of the shields also goes along to minimize this. And especially physiotherapists who are in the front line, especially in the CCUs and ICUs. It's very important that the necessary droplet precautions are observed, and by so use of the eye protection as well as masks is very crucial. And this is much has been emphasized by the Minister of Health as well as the World Health Organization. Now, the role played by the physiotherapists is we have the goals, and these goals calls upon we need to closely monitor of vital parameters of how these patients present. This could be cardiorespiratory, neurological, and of course, and other systems. Now, patient education and reassurance is very crucial, because as you all realize that the COVID-19 patients, these are people who have come across to be infected by the COVID-19, and people who are up and about doing their job or their daily activities. And there's a lot of anxiety. There's a lot of patients are anxious. So patient education is paramount as the physiotherapist comes across this patient in whatever setup. And of course, reassurance. And in terms of education, it's important to talk to the patient and how this how this disease comes, and what is the outcome, and how is his expectation from the side of the patient in as far as the physiotherapist you are concerned, the management. And of course, we look at the other goal is to reduce difficulties or reduce breathing difficulties, which is one of the major factors, and that's where we come in very strongly as physiotherapists. Yeah, and then how do we go about this? We go The goals are also part of before I go to how we go about this, I will talk about the complication associated with the prolonged bed stay. As you know, skin breakdown is one of the complications. Nerve damage, contractures, and pulmonary complication, as I've said, like pneumonias, the telectasis, and we address underlying comorbidities. If the patient is compromised by, let's say, diabetic mellitus, the cancers, vitrophyral, tuberculosis, obesity, and hypertension, these are the things you address because it's important. And as physiotherapists, we should look at this patient holistically, because as much as the patient could be presenting with a pulmonary kind of problem, but you remember, the patient we have to be looked at holistically, both in all systems, including musculoskeletal and the underlying issues. And of course, at this point, I must emphasize that patient to patient, this depends on the patient to patient, because we have the young, we have the old, and assessment, the issue of assessment comes in strongly, and be able to come out with this kind of your goals when you are setting your goals. Then, of course, we improve the patient's quality of life, which is the ultimate aim of why we come in strongly as physiotherapists. Now, how do we reach these goals? As I've emphasized in the previous slide, re-education and psychological empowerment is very crucial. You noted since COVID-19 is not only psychologically affecting the people who have received it, but as an element of stigma to go with it. It's not enough as a physiotherapist to just concentrate on the area of musculoskeletal and systems, but educate and empower the patient in terms of reassurance, and this can also go along to gain confidence and also look to achieve your objectives. Just physiotherapy in terms of airway clearance techniques is very crucial, and especially if a patient is intubated, or patient is on oxygen, or a patient is obese, and a patient is got some underlying comorbidities. And this is where you need to also assist in terms of chest clearance. In terms of suction, physiotherapists, we have to observe airway droplets, precautions, and of course, we nowadays even have the closed circuit suctioning, so every precaution must be taken. But the whole idea is that we must open up the chest and be able to make this patient lead a normal breathing as much as possible. Early mobilization, as I've said, is crucial and it's very important. Why? Because early mobilization, if these patients, as you know, they are affected pulmonary, and the more they stay in bed, the more they are not likely to receive oxygen in all the areas or to the extreme part of the basal segments of the lung. So this is very crucial that early mobilization should be done. Okay, sorry, doctor, where have I done? What has happened? No, let's go now here. Window.
Okay.
Okay. So we go ahead. So this is very important, as I was saying. All right, we can move ahead. So we have a bit of internet. Okay. So. Okay, we move ahead. So positioning in bed is very important, especially this is where I've said, like, supposing a patient is extreme obese, we have to put them in a half-lying position that's 15 to 30 degrees so that you can prevent the workload on the diaphragm muscle, especially when it comes to breathing. Respiratory muscle training is especially very important. This is the role of physiotherapists play much, and of course, agility exercise and relaxation. Now, respiratory muscle training, as you're aware, patients who have had prolonged stay, especially with intubation, they tend to weaken muscles. They tend to have weak muscles. And of course, the diaphragm muscle plays a very big role in the terms of breathing. And of course, you can see in the slide that sometimes we are talking prone, but I will not be able to talk that much because that's also another topic altogether and in terms of the improving management of this patient. But we have seen it's happening in other countries. Although in our setup, we have not gone to that extent so far. Now, in acute and subacute and post-acute stage here, we have to evaluate and the clinical parameters. And as I've said, we physiotherapists, we should not fail to look at the other clinical parameters like temperatures, SpO2 as measured by either the machine or the pulse oximeter, blood pressure, random blood sugar, and if the patient is dysenic, look at the respiratory rate. These are indications on how the patient is doing. And of course, then examination and evaluation on the peripheral muscle strength with using maybe the different scales which are available and the manual muscle tests. Then we have to look at the isokinetic muscle tests and the joint mobility in case of joint range of motion restrictions and shortening of muscles. So these are at this stage, as we look at this patient, depending on the age, depending on the circumstances, but it applies to all patients, and depending on how the patient presents, we have to look at this aspect and then come up with appropriate interventions. As we move ahead, we look at the patients who have stayed long, especially patients who have been stayed long with prolonged ventilation on a ventilator and oxygen use. Reconditioning interventions are and is very important in order to improve the physical status. Now, I've said clearly the conditioning interventions incorporate of exercises, including agility exercises, including active, reactive exercise, and including any tasks which you think a patient can be able to pick systematically and be able to attain to come out of these conditions. And here I must emphasize that physiotherapists must also be able to use simple evaluation techniques, also like 6-minute walk test and such like, or a 4-meter walk test and such like, when you are walking using this kind of evaluation and using the accepted interventional evaluation techniques. Now we move at the effects of COVID-19. As I said earlier on, most of these patients, as they present, they are those who present with a lot of breathlessness, and some of them, a great percentage, might require oxygenation, while others might require intubation. But of course, we know that scarring and fibrosis of the lungs is one of the complications, and this probably contributes a lot to the mortalities of these cases we are seeing. And of breathlessness, this is one of the observable and one of the most, as you go to the next slide, you'll be able to even listen to our colleague who will present a case. Loss of function and interdependence, and of course, anxiety and psychological issues. As we have said, these are some of the effects of this disease. Now, we call it post-intensive care syndrome. Why? Because when the patient comes out of the critical period, and especially in prolonged oxygenation, could it be intubated, and the patient have come from acute, subacute stage, and post-discharge. Patients are likely to have a presentation of various problems. These can be classified in terms of your physical impairment, activity limitation, and participation restriction, based on the ICF model, World Health Organization 2001. Now, under physical impairment, here you find like pulmonary function problems, and I've spoken quite a number of them. Muscle strength, loss of muscle strength. This is associated with the lack of activity and prolonged bed stay, and of course pain, as measured by various pain measuring. Maybe you're using a numerical pain scale and such other measurements. Now, activity limitation here, we have the exercise capacity, gait speed, and balance, and this is one of the effects of this disease on the patients. Patients are likely to be limited in terms of activities, and this, our role as physiotherapists is to ensure that this patient as a whole is able to go back to his or her activity, and of course participate in normal daily life. Now, participation restriction, we are talking of activities of daily living, instrumental activities of daily, like use of the telephone, use of the, one can be able to bathe, and of course, you talk of employment, you can be able to go back to his normal work, and of course, like driving. And of course, this is now, on this side, we see personal factors and environmental factors. And the personal factors, just we call them mostly like red flags, and the environmental factors could be also, stigma is part of that. I can put like an example. Yes. Now, evaluation and prognosis, as I said, we can use outcome measures that are valid and reliable. Outcome measures are like, of course, we use like outcome measures in ADL and instrumental activities or daily. We use cuts and such like, and then baseline measurements are obtained and tracked over time. And of course, you compare normative data, which is compared with the patient's data. Now, as a physiotherapist here, what's most important is what is the assessment and what the presentation of the patient, and there is a difference between one patient to the other. So the assessment plays a very big role. As you know, we use the SOPIA method, and this is what we apply in the clinical area, and we are able to get this to the bottom of, and then from there we compare how the patient presents. So our role here is we must have to evaluate, and from there we are able to pick on the prognosis on how the patient is going to be back to his feet or back to his normal work. Of course, the restoration functions here, we are talking of increased flexibility, aerobic training, and this has to move systematically depending on the patient you are handling. And because this is somebody who has had issues with the pulmonary function, so even high exercise tolerance might be low and may not be able to do much unless you just move from one point to the other. And that's why I talked of an element like use of like 6-minute walk test. Sometimes it could be even a 4-meter walk test, and then you gradually move to aerobic training. Aerobic training, here we talk of low impact aerobic, like just walking, and then before one is able to move to other strenuous exercise. And then strengthening and endurance is part and parcel, and we have to make sure these patients are able to undertake some activity without undue stress or fatigue. Task-specific training, and of course you move to higher level of circuit and high intensive training. As we move ahead, upon my colleague, Miriam Muli, to give us a case presentation. And then, yes, Miriam. Thank you, Dr. Kalun. That's right.
Welcome, good afternoon. My name is Miriam Muli. I'm a physiotherapist at Kenyatta National Hospital, and I'm working with patients of COVID-19 confirmed cases here at KNH. So I'll only have to present one case, and we'll have to listen for other two cases from KU University by Elizabeth Mwikali, and then another case from Michael Maina from Aga Khan Hospital. So in our case, we had a 47-year-old lady, a confirmed COVID-19 positive, who runs a small business. She's a single parent of 2 adults, and she stays alone. She presented to us 6 days ago with difficulties in breathing that had kicked in 3 days before admission, chest pain, and she had other underlying fever, and she had other underlying conditions. On examination, she was on oxygen by non-rebreather mask. She had a dry cough, past lip breathing. That means that she had increased rate of breathing. Symmetrical chest expansion. She had a loud wheeze. Bilateral lower limb swelling. She was immobile and she was obese. So in summary, we are talking about a middle-aged lady who's anxious on oxygen, 15 liters per minute, obese, and she was dependent on all her ADLs. So in our plan of management, we started by patient education. And when we talk about patient education, as we mentioned earlier, this COVID-19 is a new case all over the world. And as emphasized, we need to emphasize to the patients about hand hygiene, cough hygiene, and generally give them a brief about the disease because they are anxious. Again, you need to reduce the work of breathing by giving, breathing exercises, instructed breathing exercises, the agility exercises. Again, also to prevent immobility complications, such as, DVT, and a patient who is having a respiratory distress will likely have to complications such as heart failure, also skin breaking because of immobility. We also have to look at how to improve their dependence in activities of daily living. Yeah, to start on early mobilization as mentioned earlier, and also to improve on their quality of life. So about the management of the patient, we have to emphasize on proper donning in PPE as part of, our protection as frontliners, health caregivers. Also, we have to reassure the patient and give education. We gave instructed agility exercises in bed. We give supervised exercises in bed, such as ankle pump exercises. You have to teach the patient on how to turn in bed, and this comes in the initial stages of management, especially when your patient is totally bedridden. Then you do assistance transfers into sitting, and this has to be gradual because, as mentioned, this patient was really dependent in everything. She was on oxygen, and we have to start the exercises gradually. So we also did a 2-meter walk. So about the progress of the patient on day 3 of exercise was able to sit independently. We started transfer from bed to chair with minimal support. She could talk with the oxygen off and make sentences, and she walked 4 meters, 2 meters from the bed and 2 meters back to bed. So we maybe welcome questions, and the panelists will react to the questions.
Yes, yes.
Okay. I'm going to introduce Elizabeth Mwikali from Kenyatta University for a case presentation. Elizabeth.
Thank you so much for inviting me to this webinar. Thank you for taking the chance to give KUTRRH an opportunity to share our experience. I'm going to take you through not necessarily a case scenario, but through the experience that we have had as physiotherapists in this pandemic. So far we have had symptomatic patients. We have classified them from asymptomatic, mild, severe, and critical as KUTRRH. We have also had an opportunity of admitting suspects, and I want to take you through the experience as physiotherapists that we have had with that range of patients. From the suspected cases of COVID-19, we were able to attend to a suspect that had an oncology issue that had a bilateral lymphedema, and we were managing the lymphedema while the patient was a suspected COVID-19 case. That was the initial stages. So far, we have had a total of 11 intubated ICU cases. Out of the 11, we have lost 4 of them. We have had 2 recovered back to the ward, and the rest are still in the ICU. We have had an opportunity to attend to an obstetric case, an expectant lady that was done as CS, and as physios, we came in pre and post because the patient was in critical care with preeclampsia, sorry. And we have had an opportunity to attend to a person with physical disability, an amputee. Out of the cases that I have mentioned, in critical care, as my colleague Mogire has mentioned, all of them actually presented with the comorbidities several diabetic cases. All of them had comorbidities. I want to trauma case. While he was being investigated, they questioned the chest x-rays, and from then he became a suspect and was referred to our facility, admitted as a suspected COVID case, which turned positive. He suffered fractures of the superior pubic rami. So he was admitted for COVID positive 19 with the fractures. We did not pick the case we were not invited to manage the case until 2 weeks down the line when the patient started showing respiratory issues with inability to cough. When we came in, the patient had difficulty in expectoration, and we played our role as physiotherapists. Just a minute. We also had a case in ICU that had, we had an opportunity to attend to that had polio and presented with multiple DVT. We were able to give anti-embolic stockings and the necessary chest physiotherapy. I think in overall, that's all that I would like to share for now. What is most important for us to notice is that as physiotherapists, when we are going in, we look at the patient as whole. We look at the patient as the presentation, why we have been called in. Are there any existing comorbidities other than the COVID-19 and our role in the COVID-19 scenario of presentation? Thank you.
So I would like to introduce to you Michael Maina from Aga Khan University. Welcome, Michael.
Thank you. Thank you, everybody. Good afternoon.
Good afternoon.
Good afternoon.
Yeah, sorry, I was not informed in time that I was to present a case study, so I don't have a structured case study to present, but all the same, I can take you off the cuff through the management of one patient that we had. We've had a few patients actually, but I would like to present this one in particular. This was a 58-year-old male patient who had traveled to one of the countries that COVID at that particular time. And when he came back to Kenya, he was isolated in one of the facilities. And it is during the time of his isolation that he developed symptoms. So he was brought to us when he was already in respiratory distress. So he was admitted in ICU, and he was intubated for a few days. And after the patient was extubated, during intubation, of course, he got the normal chest physio and suction. After the patient was extubated, then we started taking the patient out of bed onto the bedside, and we did bedside exercises and encouraged the patient to do exercises on his own while he was in bed. He was only in ICU for a few days, then he was transferred to the general ward, one of the general wards which has an isolation room. So the patient, while he was in the isolation room, we started by giving him bed exercises and getting out of bed, sitting by the bedside. All this time he required oxygen, but I forgot to mention that the patient had a collapse of the right lung. So he also had an aorta seal drainage tube. So while he was in the ward, he still required oxygen, and he was actually brought to the ward while he was still on 5 liters of oxygen. So we were able to mobilize the patient in the room while on oxygen. It was quite difficult to do. He was quite weak. He had weaknesses. He had issues of balance, and of course, he was quite breathless. But he was able to groom himself. He was able to walk to the washroom and groom himself and do all his washroom activities without much assistance. One thing that was very important for him was chest physiotherapy. At that point, we started off with incentive spirometry. But what was the game changer, and this was of significance, is that when we started using a balloon is when his chest actually opened up. Okay, so when we started using the balloon, his incentive spirometry improved, and he started doing as much as 3,000 liters. So at that point, now he was able to do a lot more, and he was able to gradually come off the oxygen. So when he came off the oxygen, we started ambulating him outside the room. Of course, he wore a mask as he was walking in the corridor. So we walked him on the corridor. After some time, we graduated from walking in the corridor, and we started taking him to the staircase. So he started doing the staircase. After that, in the last week of his stay in hospital, the patient was actually able to walk out of the ward and outside into the garden. And after that, the patient was discharged, and we sent him home with a home program. And of course, we gave him contacts of a person that he can call for advice anytime that required advice on physiotherapy. So that is one case that we had, which was of quite some interest. because of the way the patient came from a very deconditioned condition to almost full recovery. I believe that this is a patient who will get full recovery within a short duration of time. So what you learn from these cases is that a patient will come in when he was walking, and within the few weeks that he's in the hospital, especially if he spends significant amount of time in ICU, what he suffers most is decondition. Okay, this deconditioning starts from the muscles of respiration, especially if the patient is intubated, to the rest of the body muscles. Not only will he suffer the muscle weakness, they also suffer balance issues and confidence issues. Okay, so you find that a patient does not believe that he can do even what he can do. So you have to motivate the patient, and you have to, on top of the training, you still have to do the motivation. You also have to look at the psychological aspect of everything, because this is a patient who, at this time, especially towards the end of the program, he starts wondering how things will be outside when he goes home, because there's still quite a bit of stigma out there. So you should also be able to assess the psychological status of the patient, and if you feel that the patient requires counseling, then you involve a counselor who can come in now and help the patient to feel like life will be normal when he goes out. So that's a case that I would like to present. But after that, there's something more I need to say. Right now, physios are concentrating a lot on treating patients who have COVID, especially after ICU. But there's something that we need to look into. If you look at most of the patients who have ended up in ICU, or most of the patients who have ended up in severe disease, these are patients who have other comorbidities. And mostly these are non-communicable diseases. These are patients who have diabetes. These are patients who have hypertension. These are patients who have non-communicable diseases in general. And in the past, physios have not taken up fully their role in the prevention of NCDs. And this is something that the physios need to take seriously and start looking at how we can prevent NCDs. If you look at the statistics that Mr. Mugire presented there, the patients who end up with serious disease are actually a very small percentage. Now, if as physios we can play our role to prevent NCDs, we will actually reduce that small percentage to an insignificant percentage. And this is a role that we need to play. And we need to engage our doctors. We need to engage especially the doctors who are dealing with diabetic patients and the doctors who are dealing with hypertensive patients. So here we're talking about the cardiologists, the diabetologists, and the family medicine doctors, so that they are able to refer these patients to us early, so that we can involve them in physical activity that is going to lessen the progress of their disease and basically make their bodies more stronger and capable of dealing with disease should it arise. Thank you.
Hello?
Hello.
This is Elizabeth again.
Yes, Elizabeth.
There are a few things that I needed to highlight. Sorry, something happened.
It's okay, it's okay.
While we are still managing the patients in ICU, I think this is important for me to highlight to all the clinicians. So far, we have noticed that prone positioning is working miracles. It has been documented severally internationally. What we have noticed is that it optimizes gaseous exchange. We are noticing good saturation. We have not been able to achieve the recommended 16 to 18 hour pronating of a patient, because the patients that we have had have been quite obese and it's very challenging. We have been having a challenge of staffing as well. So if any of our colleagues are having patients who are ventilated or even non-ventilated, this is something to really look out on, to try. It involves teamwork and it's helpful. The other thing that I wanted to highlight is on staffing and workforce of the physiotherapy team, because it's important that we safeguard each other. So we have to be careful on how we allocate ourselves to work and to cover and to go for quarantine and to go for screening and testing. The other thing is on the training for the physiotherapists on the PPE and the physiotherapy interventions themselves, whatever we are doing to the patients to be evidence-based practice. And also even at planning and the strategic operational level, involvement of physiotherapy is so key. The other thing that as KUTRRH we have seen we people need to think about is the possibility of setting up exercise programs for the non-symptomatic cases that are positive, because patients are just lying in bed. That could lead to what Mr. Maina is talking about, the NCDs. The practice also needs to adopt to the changing context of delivery and in line with the emerging evidence. We also need to think in terms of service delivery, the pathways that we need to support the transition from acute to post-acute phase across all settings. And this is a multi-professional approach which help the patient fit back into the society. Thank you.
Hello. Yeah, I would like to share one thing with Elizabeth has brought up. This is especially in relation to online. And I quite agree with what she has yes. But online is one thing which requires manpower. Two,
Mr. Mogira, we can't hear you.
sorry, are you getting me now?
Yeah, now we can hear you.
Yes, I'm saying the prone line, it also requires a lot of inputs from other multidisciplinary because it requires manpower. That's true, and I agree with Elizabeth. And again, there are other aspects of which must be looked at from other multidisciplinary team, especially in the ICU setup or CCUs. And this comes to where the role played by anesthetists and such like, because we have seen from literatures from elsewhere that it gives good results, especially in the first 24 to 48 hours, where a patient is supposed to be prone lying for 16 hours and then turn to supine for 8 hours. But of course, a lot of other complications must be ruled out because also prone lying is associated with other complications which must be ruled out because the patient must be stable. But the truth of the matter is that it's very good because it has been found to increase the oxygenation to all parts of the lung field. There is other measurements which must be taken into account, especially the SpO2 and FiO2 ratio. The percentage of oxygen saturation and the fraction of inspired oxygen must be taken into account, and then to arrive at that. But what I can agree, even as physiotherapists, especially those of us who are working in the critical areas, this is we need to take this up, and we assist the teams in ground teams in terms of making decisions to how best can we manage this patient in that facility so that we can improve the pulmonary and we can mitigate towards the fibrosis, because as we have said, fibrosis and those are directed part of the lungs are those basal segments which suffer a lot. And this is something we need to we agree. I totally also support Elizabeth, especially when she has talked of the exercise program for this, especially the suspected patients who are, or maybe who are in the quarantine, who have no, actually, these comorbidities can be prevented a lot by the team. But my colleagues also who are panelists can also chip in, but we see how best we can do this, because We know, like for example, Kenyatta National Hospital runs a wellness program, a KIFIT program, which is doing very well, and it's attended by participants from within and without. And this is one way we can minimize these non-communicable diseases, which are really a big an emergency in this part of the world. Thank you.
Thank you so much. Thank you so much. We'd like to appreciate the team that has really done a good job in this presentation. They've done justice to this particular topic. Mr. Mogire, Miriam Muli, Elizabeth Mukali, and Michael Maina. Asante sana. Now we quickly go through the Q&A section. And I agree with you. This is team effort. Healthcare is all about team effort. There's a comment from Anthony Wanyanka, and he says, this was a great presentation by all. This shows that the best patient care is multidisciplinary, and all cadres play a great role in patient care to achieve explicit outcomes. Again, thank you. So it's true. There's a comment from Martha, and she's saying, I wish to thank you, team, for the great work you're doing. This is very important, not because of the pandemic, but also it is good to note that there are some patients who have had symptoms like complications associated with the previous PTB, and therefore need to understand the role of physiotherapists in assisting such patients. Thank you for that comment. Mr. Maina, there's a question from Muleshe. And Muleshe wants a clarification about, sorry, let me just mute that. Sorry. Mr. Muleshe wanted a clarification about balloon. You said something about the patient, what worked for the patient was the balloon therapy that you gave him. So Muleshe was asking, do you mean the repeated physical blowing of a balloon? Or he wanted you to discuss more about this balloon therapy. Yes.
Yes, and thank you for the question. The reason why I was excited about the use of the balloon is because it's a very basic item which can be found anywhere. Unlike the incentive spirometer, which someone in the rural area might not have access to, and also the cost might be an issue. I was excited that the balloon actually gave very good outcomes. Yes, the use of the balloon is very simple. It's a question of telling the patient to take a very deep breath in, then blow the air into the balloon. Okay, as the patient takes in that very deep breath, so that he can be able to generate positive pressure to blow into the balloon, he actually has an opportunity to fully expand his lung. Okay, and even as he's blowing into the balloon, because the balloon does give some resistance, it also assists in the lung function. So it's as simple as that, but the effect is actually marvelous. So I was excited because of the fact that it's a very basic item and an item which is very much available everywhere.
Thank you. Thank you for that clarification. And it's true, that's something that is available everywhere, but please don't try it at home. Consult a physiotherapist, consult somebody who's trained, even if it's via phone, so they can explain how to do this. And if possible, employ them in your facility. Don't try it by yourself. There's a question also about home-based care after hospital discharge, post-discharge follow-up. I'll ask this to Marion, and I'll ask it to Mwikali and also Maina. Is there any form of post-discharge follow-up that we've managed to put the patients we've discharged on? How are they doing post-discharge? Are there any simple exercises maybe that you've requested them to continue doing at home to be able to get their full lung function? And are you also following them up, either home-based care? Is there that program where you can visit their houses and continue giving care, or they can come back to the facility and receive care from the physiotherapy department?
Thank you. It's true that these patients require to have some home program by the time they are going home. Some of the things that you tell the patients to do are very simple things. Tell the patient to take a walk, 30 minutes walk if he can manage. If not, start slow and keep building up every day. But you create for the patient an exercise diary so that he's able to track how much activity he's doing every day and is also able to record any symptoms that he experiences during the activity. You give the patient your telephone number so that they're able to call you in case they need to talk to you. But I also need to emphasize something else also. The fact that right now there are a lot of patients who need to come to hospital but are not coming to hospital because they're scared of coming to hospital. Now, if this patient we are talking about is a patient who is able to come to the hospital to do the physio in the hospital, we will encourage the patient to come and do the physio in the hospital. We need to tell the patients that hospitals are back in business and hospitals are not dangerous places to go to, because now we've put all kinds of measures to ensure that patients are safe when they come to the hospital. Actually, most of the other places that patients go to are more dangerous than the hospital itself. So yes, we give home program, but as much as possible, we encourage patients to come to hospital.
Thank you for that. Miriam?
Yes, we have been able to develop exercise programs for the patients who have been discharged from our facilities. And this is key because they need to keep their, cardio in good shape, and also to, to improve their quality of life in terms of their ADLs, for those who still go home while they are not very independent.
Thank you for that. Elizabeth?
From KUTRRH, and to be sincere, we have been baptized by fire. The kind of numbers that we have had here, the only thing that we have been able to do in that line is to manage on a case-by-case basis. Every patient that we discharge, we are giving them the case-specific home program, but we have not had any tailor-made home program for a large number of people. Thank you.
Okay, thank you so much for that feedback. Another, yeah. And somebody is asking, a patient who is asymptomatic and are self-isolating, and they are sportsmen or women, are they advised to continue with vigorous physical exercises? Mr. Mogire, what would you advise that patient?
What I can say is that the physical activity is paramount. Now, somebody is isolated and is a sports person, and this is a person, sports people who are used to very vigorous exercises. They get the effect of the training sets in very fast because they are used to high caliber of exercise. The muscles are used to exercise, and even a week or two without exercise is enough to put somebody the effect of the training are tremendous, and it's not very welcome to sports people. In fact, I have been often observing, even in the people who are at KMTC here, some of them are even younger people. I've been seeing them exercising outside, even as we pass by. What I can recommend is that the question is whether this person can do vigorous exercises. Now, in my slides, you can see, as I mentioned, we advocate aerobic exercise, yes, and maybe for the patients, it will be on a slow mode as you move out. But for somebody who is used to a lot of exercises, my advice could be just without, because most sports people are exercise with under instruction of maybe a strength and conditioning coach or coaches, or when they are with colleagues. But one must be able to do exercise because within the limit of which one is able or she is able to without necessarily injuring him or herself. And since there might not be have access to weights, a lot of equipment, this can be moderated. But personally, I recommend, if we go to WHO recommendation of 30 to 45 minutes of moderate to intense to moderate to to medium kind of intensity exercise is enough per day. And this level, there could be no stadium. This could be just in a confined area, maybe in a room or within just, it's just a physical exercise like taking a rope jumping and of course doing some bit of aerobics, which just breaks a sweat. And that's enough for the time being because this is a very short period between maybe 2 weeks. And then it will not have much effect to the and underlying issues. But as I take the challenge on this aspect, we need to move. It's our challenge to us physiotherapists. Then maybe there's a need to see how we can reach this kind of people who are actually in this kind of situation. We don't know how many they are out there, and we see how we can advise and put them in the right program. But it's always good to consult, and it's good at least we are in this forum. Maybe this is the next thing we should be able to deal with next time. So that minutes to 40 minutes of exercise daily, it's enough. It's just jogging on the spot, doing some bit of crunches, doing a bit of sit-ups, or I think this is okay. I would have wished Gerard as well to contribute on that because he's one of the instructors. Thank you.
Hello, Gerald.
Gerard is not on.
Hello, as we wait for Gerald.
Yes.
This is Mwikali.
Yes.
At our hospital, we had such patients, some isolated, some confirmed with asymptomatic, some with mild symptoms. Especially the lot of the asymptomatic and the mild symptoms were really pushing to have their exercise time. And what the hospital did, we set up a dedicated fenced open area on the grounds where they are able to do their exercise regime. We have not had any symptom or any complication from that program, and it's still running well. Thank you.
Okay, thank you for that feedback. Gerald, hello.
Yes, can you hear me now?
Yes, you can.
Yes. When it comes to exercises for the athletes, we would advise if you've been tested and you're in quarantine for a period, remember, the most important thing is going to the maintenance phase. Don't be extremely vigorous. Just maintain your exercise levels as usual during that period. That's the most important thing.
Thank you. Thank you for that, Gerald. There's also another question from a participant.
Yes.
Which you'd said you'd answer. So let me just ask it again. And this participant was saying, I used to jog and do light exercises in the evening after work. Now that is disrupted. What can I do to stay in shape?
If you're scared of exposure during your jog, because I think that's probably why you stopped doing your light jogs in the evening, then you can do your circuit training, cardiovascular circuit training within the house. All you need is a space of 3 by 3, 4 by 4 meters, and you can do your sport jogging, a set of exercises that can be done, which can as well be, I can write them down here so that you can have a small program to run with.
I think to add on that, sometimes back, the Ministry of Health tasked the Kenya Society of Physiotherapists to come up with some guidelines on home activities for Kenyans to carry out during this period of isolation, not of isolation, this period of lockdown. And I'm aware that Gerald is part of that task force, which is currently developing that guideline. So I think that guideline will be out in not a very long time. So it's going, the Kenya side, the physiotherapists are actually doing something to make sure that the country remains fit during this time of lockdown. And that document will be public, I think, in a short time.
Thank you. Thank you for that feedback. There's There's a question from Mary Goretti. As we're almost winding up, we have 10 more minutes. And she's saying, we've seen that physical exercise reduces cardiorespiratory diseases by 35%. As physiotherapists, other than focusing on already infected and those with non-communicable diseases, I think it's also very important to educate people or come up with an exercise program for those not yet infected or diagnosed, so as to reduce the burden of disease and improve the quality of life. Now that a lot of movement has been restricted, this will also help reduce depression and other risks. That's true. Thank you for that. There's also somebody who's asking for exercise regime. She's saying she loves running, but she has pain ankles. He or she has a lot of ankle pain nowadays, so they love something else. From Sarah Karongo, she's saying staying at optimal level of physical activity for sportsmen is crucial so that they don't lose their capabilities. That is true. Rose Njoroge is saying that was a great presentation, and we acknowledge the great and much work you're doing as physiotherapists. Personally, I know how much work and passion you put into your work. Please keep safe. PPE is donning and doffing. Perfect, since you are really closely involved with the patients. I hope you have your psychological needs attended to or met. If not, you could get in touch with us at the counseling psychologist. We're here for the patients and staff in KNH. I'm willing to arrange that for you. So my question goes to Miriam and Mwikali and Maina, who've presented cases of patients that they've managed. What PPE do you wear? And I'll start with Miriam, and then we go to Mwikali and then Maina.
We are putting on the suit and the glasses, also the boots. Yeah, basically that, and the N95.
Okay, thank you for that.
Hello?
Hello?
This is Mwikali. This is Mwikali.
Yes, we can hear you, Mwikali.
Regarding the PPE, what I would like to say is that according to what we have experienced so far, every physiotherapy session or procedure we are considering it aerosol generating procedure. Whether you're working on the limbs, because you find that in most of the time you're being called in to see a patient because of the comorbidity factor that is triggering an incident that requires physiotherapy attention. Other than the ICU, where we have to really like major on the aerosol AGP procedure, the aerosol generating procedures, even in the general wards, the procedures that we are doing in themselves they are all aerosol generating procedures. And really, I would like to call on all physiotherapists who are attending to COVID-19 positive cases to consider all cases as aerosol generating procedures. In what we do, when you're activating any movement in a patient, you'll find that the patient starts to cough. That in itself becomes an aerosol generating procedure.
Okay, thank you for that. That's true. That's an aerosol generating procedure.
So in summary, what we are doing, we are putting on everything. We are putting on full PPE from the goggles. Yeah.
Okay, sorry, we seem to have lost Mwikali. Probably network issues. Michael Maina.
As Mwikali said, most of physiotherapy procedures are aerosol generating. Actually, physiotherapists, I think, are the only medical cadre who tell the patient to cough as a means of, as a treatment. And so obviously we are most exposed to any aerosols that come from the patient. So the minimum PPE that a physio can put on is an N95 mask and a shield. Even when you're not mobilizing, you're not doing a chest procedure for the patient, if you're, let's say, mobilizing a patient who is not very, very strong, we come into very close contact with the patient. Actually, a physiotherapist cannot maintain distance from a patient because everything that we do is hands-on. We do everything with our hands. So either you're doing a chest physio or you're mobilizing the patient, you are going to come into less than a meter of the patient. So you must make sure that you put on appropriate PPEs for the procedure that you're doing. However, we must also take into consideration that PPEs cost money and they are extremely expensive, and a lot of the times the cost will go to the patient. So let's not be guided by fear, but be guided by knowledge, so that you're not donning the full gear when you're mobilizing a patient who has already tested negative after treatment. So, but at no point do you see a patient without making sure that you have an N95 mask.
Thank you. Thank you. It's true, your safety first. And as you've said, your procedures are aerosol generating procedures, and it is good to take care of your safety. I'll address the last question to Gerald. Gerald, there's a question.
Yes.
Let me mute that microphone. Yes, there's a question about wearing of masks while jogging. I've seen quite a few articles, not in mainstream media, in alternative media, saying that somebody was jogging, they had their mask on, they collapsed, and this person was doing an activity, a physical activity, they had their mask on, and this happened. So just a clarification, is it safe to jog with your mask? And that's a question from Samuel Kerama.
In my view, it is not safe to jog with your mask on. The self-distancing is most important. So if you are jogging, ensure that you're running in a clear known path. So you know where you're going, you know probably you will not have 10, 15 people crowding into your area. You won't have someone less than 1.5 meters of where you are. Remember, as you jog, you breathe heavily, and there'll be aerosol projectiles as you jog. Remember as well, the reason why the mainstream media has a lot of articles about people fainting and the likes is because when you have a mask on, you reduce the amount of air coming into your lungs. So you'll definitely have, and remember, as you jog, you need a lot of oxygen to go in so that you can produce the energies that you need, the aerobic respiration. So you will tire much faster. And if you have any comorbidities, if you have any issues, high chances you may end up either fainting or something of the likes.
All right, thank you so much for that. Mr. Mogire, would you like to add something to that?
Yes, what I can say, and I think I mentioned it, that it's a lot of people, because of this partial lockdown, they have taken up to doing an exercise, something which they had never used to do before. And for us, we are now people who are scientists in this game, in this field. It's important to advise people that low impact aerobics is what we recommend. And when you are doing low impact aerobic means, actually, you are able to hold a conversation as you are doing this exercise. That way is when you can, that's when you know the difference between the low impact and high impact. So what we are witnessing is a situation. Typically, if you look at every day, people are on the road. Even people have never gone for jogging because now of this curfew and such, like they are now on the road. So what Gerard has said is very important, that it's not recommended, because if we have somebody jogging really high speed and they also have the mask on, anything can happen. So we advocate low impact, and low impact aerobics, I'm talking like brisk walking. You can hold a conversation when you are doing brisk walking. And even the WHO says a brisk walking for 30 to 45 minutes is enough. You've done daily, and it's enough to maintain somebody's healthy or the physical healthy. Yes, thanks. That's what I can add.
Right, thank you for that. Joseph Colley, I've noted your hand was raised. Would you like to add? Or
Yeah, yes, I would like just to add that during this time of COVID, most of the people are trying now to exercise and then remove their boredom when they're, to avoid that being inactive. So when they run or when they walk in the road, you find that most of them run in a group or they exercise in a group. In that way, it's very dangerous for them because of what we call social distance, keeping the social distance. So what we like to advise them when they are running and when they're in groups, when they are walking, it's safe for them to have their mask. At the same time, it's safe for them to keep that distance because of, we know these aerial secretions can be excreted when somebody is breathing in and out. So to prevent that, we need them also to keep that distance. Or if they cannot find a good space for them to exercise, it is safe for them to exercise in their house. As my colleague Gerard said, you can take a small room of 3 by 4 meters, or you can climb the stairs in your house if you have stairs. You can use that as a way of exercising instead of exposing yourself into the outside world that you don't know whom you are mingling with, whom you are running with. It's safe for you to be to keep that social distance as the government and the WHO guidelines put it. Thank you.
All right, thank you for that. I believe all your questions have been addressed, and I'd truly like to appreciate the team that took time to come and have this conversation with us. It was a much needed conversation. I'd like to ask all of them maybe to give us a parting shot. It will be good to just get their last comments as we end the session. We could start with, there's been a very active but yet silent participant, Emily Koski. We could start with Emily, go to Gerald, then we go to Elizabeth Mwikali. That's if she's back, but we hope she'll be back. We have Michael Maina, Miriam, and then we end with Kennedy Mogire, who will end the session. Hello, Emily. Okay, if Emily is not there, we can have Gerald.
My parting shots are activity is key. Let's be very active. Let's do exercises within the house. As Michael Maina has mentioned, an article may come through the MOH on what activities you can do within your home environment. Very easy. I've put up a very easy aerobic exercise program that you can do for beginners into the mid-level people. If you want anything advanced, you can always contact Kenyatta, who will tell us, and we can do a program for whoever needs it, because we know it's very important for us to be able to do things. Maintain your strength levels throughout. Remember, comorbidities are the highest problem for patients who for people who contract coronavirus. Comorbidities are the ones that pull them down. So let's ensure that we're very active, we maintain our strength levels, we are fit throughout this period, that we are in enclosed environments. Thank you.
Hello.
Hello.
Hello. Yes, we can hear you.
Yes. Thank you very much for the session, and we thank our participants. What I wanted to say is, for the active sportsmen and women, it is advisable that they do it alone. And as we are told, as my colleagues have stressed, that let them do within an enclosed facility in their homes to avoid any aerosols outside there. And the other thing about our healthcare workers, our colleague, is observe the PPE protocol. They should be trained let them assume any activity that a physio does, as my colleague Mikali has said, can create production of aerosols. So let's be careful. Let's follow the Ministry of Health protocols. And I think that's all I can say for now. Thank you.
Thank you. Thank you, Emily Koske, and thank you for your active participation in the Q&A section.
Thank
we
you.
appreciate. Elizabeth?
Hello. I take this opportunity to appreciate everyone who came on board. It was really nice and exciting to share our experiences. My last words are to my colleagues, the physiotherapists. Let us do what we can in this pandemic. Let us not, while we do it, let us not be vectors. Let us protect ourselves, protect our patients while we do what we do best. And to the stakeholders, to our colleagues, our clinicians, our policymakers, when we are deciding what to do with the patient, let us have physiotherapy involved, especially in critical care and all other wards. Let us not be called when it is too late. Let us be involved early enough so that we have best outcomes. Thank you.
Okay, thank you. It's true. Let's involve you very early so that we have best outcomes as a team. Michael?
Thank you very much. I would like to thank the organizers of this forum. I think this has been a very nice and interactive forum. I want to reiterate what I said in the beginning, that the physios need to realize that now this COVID has presented a different opportunity for them to do something that they have not been doing very seriously, and that is disease prevention. Physical activity is just as important in prevention of NCDs as anything else. For a patient who has a heart disease or for a patient who has diabetes, physical activity is just as important as the medicine that the patient takes. We need to step in into preventive medicine. We need to step in early and get our people to engage in physical activity so that we can stop these NCDs, because it is NCDs which are causing most deaths in COVID. We also need to talk to our doctors so that we encourage them to refer these patients to us. It's not enough for a doctor to give medicine to the patient. For a diabetic patient, to just give medicine. If you do not get that patient to get involved in physical activity, and also if you don't modify their diet, you'll keep on adjusting the medicines and you'll not be controlling the sugars. Same thing with hypertensives and all that. There's a huge population of elite Kenyans who are very obese. We have a role to play there. So I want to tell the physios that a lot of physical activities are being done by gym instructors. But gym instructors, they can give very general physical activities, but they cannot give physical activity as a prevention to disease, because then the physical activity must be measured and prescribed, especially if you are dealing with someone who already has an illness. So let's step in, let's play our role, let's prevent these diseases from getting where they are today. Thank you.
Thank you for that. Now we have Miriam and Mogire.
Thank you. I would like to thank the Kenyatta for hosting this, and also to thank all the panelists and all the participants who have made this session successful. My last word would be safety. Safety is very important. Let us be safe. Let us also encourage our patients to be safe and our families. If you are working in the centers, the isolation centers, the IA, the ITU, please don't properly. Do not. I know we have issues with staffing and all that, but do not. It's a buddy system, so do not be tempted to don alone. Yeah, and then the other thing is to encourage us to keep on, reading articles about this on the emerging management, compare notes with other countries and other areas who are experiencing this, and do our own research. Thank you.
take this opportunity to thank Dr. Kinuthia, Dr. Kalondo, and the research department, Kenya National Hospital, for making this this presentation success today. Now, my parting shot goes to all clinicians, physiotherapists, and especially our physicians. My request, and those who are listening to me, is that it's important to involve physiotherapists as early as possible, especially not only on COVID-19 patients, but when patients are in a critical condition, an ICU setup or CCUs. It's we should move away from what we normally call multidisciplinary to interdisciplinary, where we have to understand the role played by each person in as far as management of a patient is concerned. The other aspect I would like to call upon physiotherapists is that, and as well, again to the doctors, we have agreed from this presentation, everybody agrees that exercise is also important. And in fact, what should be there is that at one time we have been debating if that maybe a doctor, when he's prescribing medicine, in the prescription, exercise will come number one. Exercise is medicine. And this is a challenge and I think my challenge goes to physiotherapists as we are partnering up in the management of these patients. We should also not shy away from research. Research. Thank you.
Okay, thank you so much. 1 minute. Thank you so much for that parting shots, and I agree, we should not shy away from research. This is the time to document everything that you're doing, and we'll be able to learn. We'll be able to learn from you. So asante sana. I'd like to thank this team. They've done a wonderful job, and they've done justice to this afternoon session. We appreciate. On your screen is the schedule for next week. Remember, Monday is a public holiday, so we'll not have a session on Monday. On Tuesday, we will talk a lot about pediatric cases, Kawasaki disease. On Wednesday, we will talk about whether we are ready to ease down on the measures that have been put in place. And we'd also like you to note that Mental Health Wednesdays has moved to Thursday due to unavoidable circumstances. We have a psychiatric clinic that runs, a mental health clinic that runs on Wednesday afternoon. So now the team moved the session to Thursday afternoon. And on Friday, we will be talking about communication. Are we communicating effectively? So have a wonderful weekend, and God bless. See you next week. Bye.